I'm here today to talk about stroke unit care. So the reason we decided to do this topic at ASNEN was because due to COVID, a lot of stroke units are actually relocated. We decided it was a good opportunity to just wind it back a little bit and have a think about what it is that got us into stroke care to begin with. And that was about stroke unit care providing good outcomes. It's something that nurses have been heavily involved with for the last 15 or so years. A lot of other procedures and interventions have come into light recently, but they don't necessarily provide good outcomes for the majority of stroke patients. They're very much directed on a specific cohort of ischemic strokes in particular, whereas stroke unit care provides a really broad base of good quality outcomes for the most patients. So that's where that came about. Oops, forward, I'm not going. There we go, that's better. So today, the audience that this is intended for is anyone from assistant nurses, enrolled nurses, registered nurses. There will be content that's slightly relevant to stroke coordinators and stroke CNCs, but this is very much aimed at people ward-based care. Haven't got time, obviously, to go into things like thrombolysis and anything that would happen in the emergency department, but I'll make note of some of those things. So I'm going to cover what a stroke unit is, the roles of acute stroke nurses, what that care overview actually is comprised of. Secondary complications comprises the majority of what this talk is about. And then as we're caring for patients in the stroke unit, the sorts of things we're thinking about that we can intervene with to help them have their better outcomes. And I'm going to finish off with palliation because a lot of stroke units do choose to palliate their stroke patients on ward. So the relevance of this specifically is to basically increase the value that we place on ourselves as nurses as we care for stroke patients. A lot of people are happy to come in and take a lot of the credit for the good work that nursing does. And as I'll go into later, you'll see that nursing actually is really, really important in providing good outcomes for stroke patients. Obviously, if you've got a good baseline understanding of what your nursing care actually contributes to, it's going to give your patients better outcomes. And I'm going to identify some things that are particular to stroke nursing as opposed to general medical or geriatric nursing. So I'm going to cover stroke unit definitions, nursing role variations, discharge planning, and nursing care paths. So here's a slide from the Stroke Foundation. This pertains specifically to stroke unit care. And as you can see, only 67% of patients got into stroke units at the last audit. So that was actually a slight drop. And then patients who received stroke unit care in regional areas was actually quite poor. So it makes sense in that we do try and transfer patients into metropolitan or larger regional centres, but still patients are having strokes in these communities and they're not getting the better quality care as a result. Also, the use of clinical guidelines, so the Stroke Foundation clinical guidelines in particular, obviously as you're going to have more adherence to that when you're at a stroke unit, particularly because most stroke units base their care on the clinical guidelines, so it makes perfect sense, doesn't it? Some poorer outcomes of the audit showed that 31% of patients did not receive a discharge care plan. It's probably a reflection of the hyperacute and acute processes of care have changed quite significantly these days. Patients are staying a lot shorter than they used to. 40% did not receive an assessment for rehabilitation. Now, this is quite extraordinary because with that high rate of stroke unit access, you would assume that that increased allied health intervention would facilitate more assessment for rehabilitation, but unfortunately it doesn't always. Again, possibly a reflection of the reduced length of stay and also that a lot of younger people are having strokes and they might be mobile and able to go home and presumed that they don't need rehab, we're not sure. 30% did not receive risk factor education, and when I go into the next section of this talk, you'll see that that's quite significant also because that's a major part of what stroke unit care actually is comprised of. So what makes a stroke unit? The Stroke Foundation actually provides a services framework to help with this, but to summarise it down as succinctly as possible, you need a system of education for your staff so that that's what makes them stroke unit staff, not just general medical staff. You need a regular team meeting with defined structure and frequency. Now, the reason for that is if you incorporate your stroke cohort in with something like the orthopaedic cohort or the respiratory cohort, obviously the allied health are going to be pulled in every direction, and it's very hard to focus on the rights and advocacy for the patient that you're trying to discharge appropriately to the right venue, and make sure that there's a good plan in place for their ongoing care when they leave the stroke unit. The stroke team structure itself is really important. It's basically impossible to be a one-man show in a stroke unit and provide all of the elements that are required. And the preference for geographically co-located on one ward stems from the fact that there's very little evidence to indicate that a mobile stroke unit works, has the same outcomes. And a big part of that is relating to the nursing cohort, is the group of staff that don't change location. So whilst your allied health and medicine can trot about the hospital and see their patients in different areas, generally a ward is staffed by the same roster of nurses with the same training. We're there 24/7, so we're providing that consistent care. So the Stroke Foundation guidelines, they say all patients should be admitted directly to a stroke unit, preferably within 3 hours of a stroke onset. Now that stems from the fact that the longer a patient, even non-stroke patient, stays in an emergency department, the more likely they are to die or have an adverse outcome. With stroke in particular, obviously the risks that I'll go on to later in the talk are more pronounced down in emergency where they're not getting that close care and monitoring. Patients presenting to a non-stroke unit should be transferred to a stroke unit. That makes sense. And most of the eastern states I know do that where they can. They should be implementing standardised protocols, particularly with glucose management, swallowing difficulties, which I'll go into in more detail shortly. So what is a stroke nurse? The actual nursing component is not too dissimilar from any general medical nursing, but there are slight variations to reduce secondary complications and improve outcomes subsequent to reducing those secondary complications. It requires stroke-specific knowledge, though, and that's where those systems of education I mentioned earlier come into place. So modifying those nursing processes basically directly contributes to improved outcomes. And you can see this if you've been audited with the Stroke Foundation or you use AUSCA, that when you have education campaigns for your nurses, you'll generally have improved outcomes resulting within the next year or so. Inpatient stroke education. Sometimes this gets allocated to a specific staff member, but it's good for all your staff to be able to provide ad hoc education whenever the need arises. The Stroke Foundation in particular provides some excellent written education packs. They might not be suitable for the patient if they're particularly unwell, but the family can certainly read them if they're sitting there by the bedside. And they're also good for staff to read too that are unfamiliar with stroke. You can provide bedside education to the carer and relatives as well if the patient's unable to, which is important. You might have to follow up the patient after discharge. You might need to educate external service providers about the specifics of the stroke that your patient has had. Now, obviously, from a hospital perspective, this is going to avoid readmission, but also it's just going to reduce the patient's risk of having another stroke or complication from a stroke and improve their anxiety and quality of life overall. So then the staff education. You want to coordinate that as much as you can so that all the staff are on the same page. You don't want inconsistent care being provided. So you might like to run workshops, you might participate in workshops, you might help run those workshops depending on what level of staff you are. And also self-directed learning packages can be handy, easy to access the better. And some sort of reward system is always good. The Stroke Foundation has informed me that you can access as well, and there's also various university-based education and online training things in place that you can access. Access to education is probably the most important element of making sure your nursing care is consistent, because the guidelines are pretty straightforward and easy to follow once you're aware they actually exist. Inpatient stroke coordination often can be outsourced to bed managers, patient flow managers, the stroke coordinator. After hours, it could be whoever's in charge of the ward. It really does vary, and this is why having an education, a central education point is so important, because all of these people peripheral to patient flow still need to have an understanding of why it is so important that your acute stroke patients come to the stroke unit and don't go to the rehab ward, or, well, unless you've got a combined unit, scratch that. I'll call it the orthopaedic ward instead. They also, the coordinator, make sure that basically the documents and processes are being constantly updated. The body of evidence behind stroke care is ever changing. The guidelines change month to month practically. So you need someone there to then implement those changes in process very quickly. Things like license and thrombectomy are really big change implementation things that require significant multi-professional coordination to implement. So new stroke units that are coming on board obviously have a bigger workload when that comes on board, but the bigger centres as well have a lot of education and coordination involved with that, because the bigger a centre is, the more coordination is required to make that work effectively. So to basically meet all these performance indicators set by the national bodies, we need to have coordination in place. Stroke services without a dedicated stroke coordinator role tend to be far less efficient overall and have slightly less outcomes. Outpatient management. Sometimes, even though you are the stroke unit, you might be tasked with managing patients following up in the outpatient model as well. So typically stroke and TIA clinics are the way that this is achieved. Some have short stay units as well and try and get all of the tests and procedures done before they've gone home the first time. There's different billing models and methodologies. GPs are often involved with these. Again, that admission avoidance comes back in. If someone's had a minor stroke and can have all their follow-up done as an outpatient, then that's obviously beneficial to the hospital system, but you don't want that to be outweighed by the risk of them having a major stroke without proper follow-up. Length of stay reduction, billing and income can be generated from this model, which can be important in smaller centres that rely on income, and there's going to be a diagnosis and coding improvement. So whilst it can be burdensome to manage your patients in the outpatient model, it can be beneficial to your overall stroke services and your outcomes. OSCAR, so you might not be the person tasked with collecting OSCAR data, but you will inadvertently be contributing to OSCAR data by the things that you do when you care for your stroke patients. They provide a 3-month follow-up phone call to check up on outcomes, which we then use again to help service change improvements, inform them. It's a national registry, and basically, even if you are unaware that you are contributing to OSCAR, you are contributing it by the care that you provide, because it's all being monitored. You've got to meet national standards now, so there's elements of stroke care that are a national standard. Part of that is contributing data as well, I believe now. So the Stroke Foundation also have a program, Stroke Connect. I can't claim to know exactly which sites it's in, but Queensland had it for a long time. It helps mostly for me, it helped meet National Healthcare Standard 2, which was the consumer feedback. It's really good to get that someone else external to the service providing feedback for us, because obviously they'd be more open and honest. And from that feedback, we would then implement changes to make sure that that feedback was improved all round. So if it's possible for you to join up to that program in any way, I would recommend it. Stroke Foundation audit, similar to OSCAR, even if you're unaware that you are providing information to these audits, you generally will be, because the care that you've been provided gets audited every second year. And this is the main gauge that Australia uses to monitor how its stroke care is improving. It changes ever so slightly each 2 years based on what evidence has changed. Research is another one that you'll be contributing to without knowing it. So at any given time, there are massive research projects going on throughout the country looking for how to best improve stroke care, be it an intervention or a process change or a protocol change. At some degree, it will be getting researched, even if it's just at a statewide admission data level. So, for example, if you have a higher than normal amount of your stroke patients dying, that will be getting monitored in some way, shape or form. And if you look at the papers, you can see a lot of these national and statewide research investigations going on, and you, by default, are contributing to those. So don't sort of think that you're completely external to research if you're not some sort of research officer or a coordinator. You are still contributing to these data sets that are providing these outcome measures. Just throw in, so if you happen to work in Queensland, we have a stroke unit endorsement process, which is quite labour intensive. So you've got to put in your OSCAR data for more than 75% of your cases. You've got to try and aim for 75% of your patients getting to a stroke unit, maintain all these different quality indicators and documents and processes. But subsequent to that, you do get an incentive payment, which is quite a substantial amount of money, and it generally more than compensates for the cost of a stroke coordinator. So it's not entirely a lost effort. Okay. Other job that you'll have to do is bureaucracy management. So compiling business cases for ongoing stroke nursing, FTE creation support. So basically you're always feeling you're understaffed. If you've got a bit of data there that you can wrangle, you can always help get your staffing improved. Whoop, gone too far. Just like that. So the main part of stroke unit care is that discharge planning starts on day one. So the family and multidisciplinary conferences, doctors, social workers, physiotherapists, speech pathologists, occupational therapists decide what services and resources will be needed when the person gets home. Minimum of carers and next of kin need to be included in this, but it may be the whole family. And obviously that plan is going to change if the patient's condition changes. You want to start reducing risk factors day one. So often it's assumed that this is the domain of medicine, your cholesterol, your heart rate, arrhythmia type drugs, blood pressure lowering, things like that. But also there's the lifestyle related diseases that we can contribute to, as well as managing diabetes properly. Having talks about it's a good time to quit smoking, not just for the person that's had a stroke, but also the family around them, because they've now got a familial history of stroke, so they might like to give up smoking and drinking too much. And there's a doctor that I work with, I've left this slide in, but he used to say you can never be too thin, too rich or too beautiful, meaning it doesn't matter how healthy you think you are. Once someone in your family's had a stroke, now might be the time to rethink about how healthy you really are. Stroke is considered a lifestyle disease, so like heart disease, lifestyle modification to decrease the stroke risk significantly. The main thing that I find with this over the years of looking after stroke patients is that that was the opportunity to introduce the conversation to the family members as they were coming up to visit. Quite often people always think stroke is something that happens to older people, it's something that happens to someone else, but it is a significant disease in Australia. So use those opportunities of engaging with those relatives about their risk factors, and leaving those education materials around for them to read is always helpful. Refer to external programs whenever you can. So the risk factors, as I was saying, age, you can't change, race, you can't change, family history, you can't change, hypertension within reason, you can change through lifestyle modification, diabetes, smoking, blockage of arteries, high cholesterol, obesity and sedentary lifestyle, and AF. If possible, refer on to external programs wherever you can. So acute stroke units, are they a treatment? It provides comprehensive acute care and early rehabilitation. It's associated with reduced morbidity, mortality, better outcomes compared with general ward management. Better outcomes are attributed to immediate access to diagnostics, continuity of care from specialised multidisciplinary team, and stricter adherence to clinical protocols and access to rehab. So they're all the things I've already mentioned. If you follow a structured care path and adhere to the guidelines, I have updated them, it will reduce your length of stay. Obviously, your length of stay should be determined by stroke severity, depending on bed pressures. Suitability for discharge or rehabilitation, with increased home services or future placement in an extended care facility, or hopefully not palliation, but it does need to happen. So care, which incorporates complication reduction and management, but also early rehabilitation, is the stroke team. So it can be doctors, nurses, I'll call those discharge planning nurses, Physiotherapists, occupational therapists, speech therapists, dietitians, social workers, pharmacists, mental health specialists, maybe neuropsych, can all play a part. Social workers in particular over the last couple of years have really taken a lead in the discharge planning. Care pathways, this is Stroke Foundation information again. If all Australian stroke survivors had access to coordinated stroke care, outcomes would improve to 900 more people surviving stroke, 1,500 more people regaining independence, and 1,500 people returning home post-stroke. So this is why coordinated stroke care in a stroke is something that we still need to push, irrespective of things like thrombolysis and clot retrieval having good outcomes as well. Starting and continuing to rehab, interventions should be carrying on post-discharge. So now I'm coming in of why stroke nursing and stroke unit care are so valuable in stroke care. So I'm talking about complications, which ones are medical complications and which ones are nursing complications, which is which and what's the difference. So, just going to race through them. So pneumonia, urinary tract infections, it can include retention as well, deep vein thrombosis, pulmonary embolus, impaired skin integrity, which can be skin tears, excoriation or pressure ulcers, hyper and hypoglycemia, gastrointestinal bleeding can be a big one from the medications we use, seizures, then there's bowel incontinence and constipation as well, delirium, depression, falls, pressure injuries, dehydration, malnutrition, pain, extension of stroke. So when you go through all of those, you keep in mind that these can be gradual. They're not going to necessarily be sudden, Met call worthy. They could be something that's slowly creeping up and you might not notice if you don't pay close attention. Death from these complications is more common than from stroke itself. So years ago, Professor Sandy Melton nutted out exactly which interventions we could monitor more closely to provide better outcomes. And in particular, she noted that monitoring temperature, blood glucose, and doing a swallow screen would enable better outcomes with a significant reduction in death at 90 days. So how do we tell how bad a stroke will be? Basically, to perfuse the area where the stroke occurred. So a slight raise in blood pressure can actually help reduce ischemia. So from that, we need to monitor blood pressure clearly. We want to get that blood to that lesion and we want to basically help reduce where we can the size of the infarct. So what do we do as nurses to monitor what's going on with the actual patient so that we can report back to the medical team what's happening with them? Obviously, first up, we want them to have their medical review. That's all of their investigations as quickly as possible. Most emergency departments won't do a Cat 1. They leave that for the high-grade trauma, but you want the equivalent of someone basically coming in and treating them as a critically unwell patient, even though they might not appear unwell compared to, say, something like a heart attack. Speech pathologists are generally the first allied health person that will come on board because aspiration pneumonia is obviously the first thing we want to assess risk for. In their absence, most nurses in stroke units should be trained to do a swallow screen assessment if the speech pathologist is not available. Physiotherapy, occupational therapy and dietitian review should be encouraged as soon as possible, but most definitely before discharge. A lot of people, particularly those that are still mobile after stroke, miss out on some of those assessments, and it's to their detriment because they could have had subtle issues that did need some rehabilitation, even if it was as an outpatient. And then obviously referrals to all of the other allied health members that can help along the way are ideal. So monitoring and observation. So there's a bit of disagreement about what type of OBS should be done as what we call the neuro OBS. So standard would be the GCS, which isn't actually a stroke score, but the benefit of it is that most nurses can do it quite easily and it's reasonably quick to do. What your hospital chooses to use then affects basically the education structure that's required to maintain everyone's competencies in using it. There's a few different scales that you can use for that. For thalia, at least QID is important. Reason being that if you've handed over from your shift and someone else has come on, if you haven't got an accurate record of how conscious they were or how well they were, and they deteriorate, then you've obviously lost the opportunity to met call. I'm going to use the word met call, sorry, but that's our version of a code blue. Blood sugar monitoring, as I've already mentioned, at least 4 times a day for about 72 hours. You're monitoring for hyper and hypoglycemia there. And then obviously you still want to treat any of these variances as a code blue and not just limit that to cardiac related variations. Koku does a good talk on the deteriorating patient as it relates to stroke, which goes into more detail there. Neuro-obs can be ceased roughly after about 72 hours if the patient is stable. The other one I threw in there in the initial immediate obs was a ward test urine on admission. A lot of patients come in with chronic urinary tract infections, and once they've had a stroke, the chances of that brewing up are quite high. So it's good if you can catch that on admission rather than wait and see and end up having it worse later on. Something that obviously I mentioned earlier that we want the brain to be reperfused, and obviously you need oxygen for that to happen. So keeping the patient oxygenated is important. But the thing is that we must remember not just to throw oxygen on a patient if you find that they have a lower saturation. It's important to make sure that their body position and slumping isn't what's caused that. Ward test urine, sorry for the person that asked. And depending on which state you're in and which hospital you're in, some people actually restrict the use of oxygen, that it must be ordered by a doctor. If someone's hypoxic, it's not the end of the world to do a chest examination to check that they haven't got a pneumonia or similar developing anyway. So you have to use your clinical judgment there as well. Blood pressure monitoring, I've already mentioned that we would be expecting a slight raise in systolic blood post-stroke. A lot of forms in health have ranges set as to what is the criteria to have a medical review, and with stroke it is allowed to be slightly higher. So it's important with those systems of education that I mentioned earlier that your doctors and nurses are aware that the ranges are slightly different. And same again on the other side for intracerebral hemorrhage, it can be lower. So just keeping an eye on your staff and how they are medically managing those levels is really important. And usually if you're having any trouble with that, some doctors will provide standing orders to assist with basically repeated calls because someone's blood pressure is slightly higher than what the normal ranges are. In saying that, though, even though it's acceptable to have a slightly high blood pressure post-stroke, you don't want to decrease it artificially too rapidly because, as I've already mentioned, you need that blood oxygen getting up to the brain to help the lesion not get too big. Blood glucose as well, so you just want to keep it normal. So there were many trials many years ago where they tried bringing it down if it was above 10 with insulin infusions, to see if that decreased the size of the stroke, but to the best of my knowledge, they were never successful. So now we just focus on making sure that the blood sugar is within normal range and not worry too much unless it starts going over 10. But for that reason, it is important that we keep monitoring it. Temperature again, so this comes into the FEST protocols, which is fever, sugar, swallow. Someone's asked the question there. We want to keep that temperature lower. Now, there's a problem with this. So the evidence indicates that if you are pyrexic, that your lesion will worsen because of that, or the effects of your stroke will be worse because of that, and that if you bring it down, your outcomes will be better. Now, the two problems with this that nurses need to be aware of is the first one, if a patient in particular has had, say, a dense hemi and are unable to move themselves or they're semi-conscious, you have to check their local environment. Some wards can get quite hot. Sometimes going through ambulance and emergency and CAT scan, they can have a lot of blankets put on them. So it's important to check that there's not an actual cause for that temperature going up. It has happened. The other thing is that you aren't missing the opportunity to perform an infection screen. So be it a urinary tract infection or a pneumonia, or it could be just a complete coincidental infection of another cause, we do maybe want to look at the opportunity to do infection screening at that point in time before giving Panadol. The other single issue that can happen with that particular range that has been set is some hospitals actually have criteria for when they can and can't do things like blood cultures and chest x-rays, and the cutoff might be 37.8. So that's another example of where you need good systems of education so that your hospital is aware that with your stroke patients, you might want to do things just slightly different to what their usual recommendations are. Is an example of a stroke observation form that's different to a normal one. It's got those ranges set that are basically variations to normal medical nursing. So this follows best management guidelines, but then it's incorporated local rules, regulations, policies, cultural procedures, and they can get quite tricky. It would be nice to have a national recognised observation form for stroke based on evidence, but the problem with that is we're all using different electronic medical records, paper medical records, and as I mentioned earlier, the evidence changes so frequently, month to month practically, that it would be hard to keep such a form up to date at any given time. Platelet and anticoagulation therapy, I'll zoom over a little bit. Another changing space, but basically as nurses, it's our role to give them on time, make sure that they are given when ordered, and if necessarily, prompt doctors as to what you can ascertain they were on previously when they last took it, things like that. Sometimes nurses are the people with the relatives that can find out little bits of information that might otherwise be missed. A really good example I've got is a patient sat there and told their doctor about their warfarin in great detail about when they last took it, and I know that they had actually stopped taking it 2 weeks ago because their wife told me, and she was worried that they had the stroke because they stopped their warfarin. So, you know, keep your ears out and be monitoring what patients were on, not just what they're taking that you're administering to them as a nurse on your daily rounds. DVT prophylaxis in general. Queensland uses Plexane as routine for all admissions now, and last time I checked, continuous compression devices were recommended, but TED stockings were no longer evidence-based. So hydration and nutrition, now we're coming into the true realm of the nurses. Not the job of a dietitian, it's their job to make sure that the patient is on the correct diet for their needs, but it's our job to make sure that patient actually gets to eat, so, or not eat, more so. So nil by mouth until speech review or swallow assessment has been done. Hopefully that is ingrained in everyone by now. There are a lot of people that try and eat around this if they haven't got time to do their swallow screen, depending on what method of swallow screening tool they're using. Some people will say doctor said they're okay to eat and drink even though the screen wasn't performed. This is based on the fact they had a conversation with the patient, they didn't have a swallow screen at all. Nutritional status does need to be reviewed. Nurses habitually will be more likely to nutritionally screen thin, frail patients, when quite often obese patients with high cardiovascular risk factors are also nutritionally compromised. So dietitians are great to help with stroke risk reduction in that regard as well. Weigh as soon as possible, obviously with all the different types of drugs we use in stroke. Weight is super important, but also for nutritional purposes, monitoring, especially if they are nil by mouth and they don't particularly like their new diet or they're on a modified consistency post-stroke. Apply the speech therapist recommendations regarding diet consistency and feeding techniques. I think standardised textured diets have helped a lot with that in the last few years. Back in the olden days, you used to mix up your thickened fluids in the kitchen, and that was a bit bodgy. IV rehydration or nasogastric placement, there's various pathways and various ways of managing that. So typically if someone was to come in on, say, a Friday afternoon, they had to be nil by mouth because the nurse assessed them as failing their swallow screen and the dietitian wasn't on, there needs to be consensus in your service as to whether they are basically going to fast for a great many days until the dietitian comes back, or if you're going to have a standing order in place to commence nutrition nasogastrically and IV. So that's a systems-wide intervention that you need to consider. What's right for you. Most weekends, it's not the end of the world. When it hits is when you've got a 4-day long weekend. That's generally what will trigger people to put in some sort of standing order for that. Mouth care, I could do a whole 1-hour talk on. So this would be the single biggest area where even if you are nil by mouth because you failed your swallow screen, you're still going to potentially have your normal saliva aspirating down your throat. So if you've got poor dentition, you know, not necessarily any sort of infections, just a grubby mouth in general, that's going to go into your lungs. So providing regular mouth care is really important. A lot of people post-stroke also commence mouth breathing just because it's a more open airway for them. It's easier to breathe. And obviously with that comes an increased bacterial load in their mouth. So regular mouth care is really, really, really important. And then obviously monitoring dietary intake at the direction of the dietitian. So not everywhere has a food chart as standard, but I notice a lot of nurses, the meal time is often at the medication time. There's a lot of presumption on what was and wasn't eaten, what was and wasn't taken away by the kitchen staff. Some hospitals have had to implement variations of what they call a red tray system, where if a patient is allocated a red tray, the kitchen staff know that they are not to take that tray away until the nurse has inspected what was and wasn't eaten. There's also use for volunteers and family members to assist with feeding. This is one area where assistant nurses really come into their own, making sure that patients are getting access to the food. It's important to remember that even if someone has a modified diet and it's apparent that they're not enjoying their diet, it's important that we help them get the nutrition that they need to recover, because without good nutrition, their poor brain can't recover, let alone keep their muscles active for all of their allied health interventions. Continence management is one I literally do a 90-minute symposium on. So when I first started in this game, indwelling catheter avoidance in stroke patients was a passion of mine. They were very common back in the day. People would want to take a urine specimen and they would just basically use an IDC to collect it and then leave it in, on the assumption that it would be easier to manage a stroke patient with an IDC in because you didn't have to take them to the toilet. So with that comes massive consequences. First of all, if they're newly incontinent or if they're not, you don't necessarily know. If they develop a urinary tract infection, it's a lot harder to detect. By the time you detect it in an IDC, it'll be when the urine is clouded. Well, that's way far too gone. It affects continence irrespective of whether you've had a stroke. If you leave it in for those first couple of days and the brain's reflexes associated with going to the toilet are altered, basically it's a lot harder to monitor the neurologic effects versus pre-existing incontinence. There's a fair bit of ageism in overuse of IDCs, in particularly elderly patients, as the assumption that they'll be incontinent when they in fact won't be. It was actually just the fact that they couldn't physically get to the toilet in time. So overall, you probably gauged already, I'm quite passionate about that topic. We want to make sure we've got a continence management pathway that enables the patient, wherever possible, to actually use the toilet. So not use a pan, to sit over the toilet so that they can have their bladder and bowels open fully. Obviously, if you need to get physio and occupational therapy involved with that, if you need to get assistant nurses, if you need to do timed toileting to assist with that, well, that's what's going to be required. If you rely on pans, it's an unnatural position, and especially post-stroke, very difficult to position yourself over a pan. You never fully empty your bladder and bowels, and so it can cause more trouble than it's worth. And at the end of the day, using those aids instead of toileting, whilst it might appear to be quicker, it actually ends up taking longer when you add all of those instances together, as opposed to getting up and going to the toilet 2 or 3 times a day properly. And it's also important to remember that incontinence is actually one of the indicators that will make a person end up needing to require nursing home care, as opposed to going home with light assistance. So anything we can do to avoid incontinence post-stroke has massive, massive implications for the patient's benefit. I think I've rambled on enough about that topic. Hang on. So this is one that the Stroke Foundation can tell us quite clearly that we're not screening well enough. Big problem with reduced length of stay. So post-stroke depression, you can have it as a result of, say, decreased mobility or decreased communication, but you can also have it as a neurological side effect of your stroke. It's really hard to assess a patient if you've never met them before, so this is where talking to relatives is really important. To the best of my knowledge, routine use of antidepressants to prevent post-stroke depression is still not currently recommended, but there have been a lot of trials. I'm happy to be corrected if I'm out of date on that one. So we're trying to improve uptake of mood screening basically, but it's kind of continually falling into that we might have to do that in rehab, we might have to do that in outpatient clinics. Now, if a lot of patients aren't being followed up, as I indicated on the slides at the start that the Stroke Foundation provided, then obviously that opportunity to mood screen isn't getting done. So it's important that we look into that a bit more. Mobility, so obviously falls risk is huge for stroke, especially with impulsive strokes that just aren't aware that they can't stand up. We also need to be aware of the environment, so making sure that trays are within reach, rails up, rails down, bed lowered. There's all sorts of falls management processes that do apply well to the general medical cohort that can be used. Sitting patients up and out of bed and taking patients for showers are actually good means of assisting mobility, because they facilitate basically an interaction with the ward, with the other staff, with the other patients, so that the patient is less likely to be bored, more easily tired, and so they'll sleep better. But when they are awake, they're getting the most out of being awake because they're sitting upright and able to do more. But obviously apply your physiotherapist recommendations. Activities of daily living is the other thing where nursing comes into its own. So clients with confirmed difficulties need to have a management plan formulated, but from a nursing perspective, it's important that we don't just manage them in bed. There's an opportunity, even if you have to manage it between occupational therapy, physiotherapy wards, people and assistant nurses, to get that patient up and about where you can for their activities of daily living. So predominantly showering, I find early in the morning, during the shower, they've had their breakfast, they're at their most awake, they're able to initiate elements of their own care more readily because it's automated. It's natural for someone to, say, pick up a washer and try and wash their face. It's not a forced, you know, something that they would do on instruction. It's something that they would do naturally. So if you're there witnessing that and able to then report that back in the charts to the other allied health professionals, you're going to be providing basically an insight that they might otherwise miss. For example, if the speech pathologist doesn't come until 1 o'clock in the afternoon, and by then they're tired and they need a nap, well, they might assess them very differently to how you did in the shower that morning. Obviously, being upright just makes you feel better too if you're having a shower as opposed to a bed bath every day. That then, by default, avoids you institutionalising stroke survivors. So it's very easy, particularly with dense hemiplegic stroke survivors, for them to basically just be hoisted in and out of chairs mechanically, very routine. It can be quite degrading for them, but it also stops the onus on them to start initiating elements of their own care. So if you can try and avoid that and use more of a rehab model of care than an acute, quickly we must get through the showers before 10 a.m. type model of care, that would be good. The other issue is avoiding these complex hygiene cares to unqualified staff. Now, by unqualified, I don't mean not registered or whatever. I just mean people not necessarily experienced with stroke specifically, because you do have shoulder care, leg care, and things like that that do need to be considered, as particularly when you're transferring your patients. 15 minutes to go. Cognition and perception. So all clients should be screened for cognitive and perceptual deficits. The occupational therapist, this is generally their domain, but it's important that nursing staff incorporate some of these deficits into their care. So that's where these weekly meetings, good charting, good communication, and reading each other's advice is really important. Won't go in too much about that. Pressure ulcer prevention does come across from general medical care, and most hospitals, I think it's a national standard even now that most hospitals will have something, but particularly for finding a happy medium between falls risk and pressure ulcer prevention in an impulsive stroke patient can be quite the difficult balancing act. So sometimes lowered beds might be the option there. So collaboration and goal setting, weekly stroke team meetings are important, at least, if not more, specifically to stroke clients. As I mentioned, other patient cohorts can be quite demanding, particularly on allied health priorities. Family meetings would be ideal if you could have them incorporated, but for various reasons, sometimes that's just not possible. Relatives often work when the allied health are all present. So as long as you've got a system to communicate that meeting outcomes to the family and the patient, that should take over that. The patient's going to rehabilitation, touring as soon as possible so that they've got insight as to where they're going next is ideal. If appropriate, early introduction to stroke support groups, not just for the stroke survivor, but for their family as well. The Stroke Foundation generally has a list of those available. Oh, I've also got the online Enable Me as well. So discharge planning is coordinated client care amongst the multidisciplinary team and the family. It should be flexible because recovery rates are going to vary at the acute recovery stage, and they could get really well and then have another episode and be back to square one, or one of the secondary complications that I mentioned before. Once the appropriate discharge destination has been determined, then the rehabilitation planning has to gun-ho to try and get them as close to pre-stroke status as is likely to be obtained, aiming for best functional status within that setting. So this, the acute aged care service, is an acronym, sorry, someone asked that earlier. It's probably changed names now again. If they're going to aged care, and discharge planning, social work can come involved there. So we've got 2 minutes left, going into the longer term planning. So these are things that we identify in the acute stroke unit that are going to have longer term effects. So even though they might only have a short stay of 2 days, 3 days to a week, these are things that we can note when we do our charting that are going to impact their eventual discharge destination. So I'll just quickly read through these. A self-care deficit related to impaired mobility, cognitive and communication deficits, which affects toileting, bathing, hygiene, dressing and grooming. So these are the ones where what we are intervening with can basically directly affect their likelihood of going to a nursing home. Skin integrity related to impaired mobility, fecal and urinary incontinence. Again, this is where good nursing care, making sure that all of those things are managed well, can have a longer term effect on the patient and how they are deemed as being coping and able to return home. Same with incontinence for the same reason. This one is important because it's really hard to tell what's a neurological impairment versus what's one that nursing care actually generated through poor continence management. So again, super, super important. Communication deficit related to cognitive deficit and language barriers. This is one where we need to basically work out what level of training a carer might need. as nurses, we take for granted that we are able to communicate non-verbally. If someone wants to take their their relative home, we need to be able to explain what we think they would and wouldn't be able to communicate with using non-verbal cues if appropriate. Risk of imbalanced nutrition, hydration related to dysphasia and communication deficits. So the same again, someone might be deemed as not being able to feed themselves when in reality it was that the nurses were too busy to push the tray next to their bed every time. They could be deemed as not initiating feeding themselves. They could also be deemed as being impulsive when all they were trying to do was reach for their food. So again, these are significant outcomes for a stroke patient that were directly attributed to nursing care being provided in an ideal way. Risk of aspiration related to mild dysphasia and hemiplegia affecting body positioning. Again, this is something where nurses should take the time to sit your patient up properly prior to meals, make sure that they are alert, position the food appropriately, make sure it's the correct texture diet that got delivered in the first place. So can you imagine if someone got aspiration directly as a result of the fact that you forgot to put their bed up and they started trying to feed themselves too soon? I've actually seen that happen with quite a detrimental outcome, and it was just, you know, a nurse that wasn't paying attention at the time that it happened to. Impaired mobility related to hemiplegia, so that's the big one. So over the first 3 months post-stroke, patients can get better pretty quickly, but if you don't actively engage them in their activities of daily living by helping them sit up, helping them get up and have a shower when they can, using modified equipment still, but still, you know, nursing them as though they are an upright, mobile patient to the best as you can, then that's going to help them get better quicker. If you nurse someone in bed, they are going to stay in bed. Impaired social interactions related to communication and mobility. Same again, getting a patient up to the bathroom, getting them sitting up in a lounge room or a dining room with other patients, other staff members, other visitors is really good for them and helps them get better quicker. Compromised family coping related to new disability of a family member and change of family roles is huge. The biggest single thing to keep an eye out for here, which I've come across quite a few times over the years, is when someone, particularly young people, have a significant stroke and the spouse is presumed that they'll be the carer, and it turns out that their marriage or their relationship was not that good to begin with. We start discharge planning with the assumption that they are going to be the carer, when in reality they were of the assumption that they weren't even going to be their partner. Now, these are things that as nurses, we are in the right place at the right time, often after hours when visitors are coming through, and you can pick up subtle mood changes and communication changes between family members a lot more clearly than, say, a doctor doing a formal bedside review of a patient ever would. So rehabilitation, mindful of the time there. Not all stroke survivors can access rehabilitation. Many feel that they don't need it. Often there's just not accessible rehabilitation. Often young people in particular are not even offered it just because you can walk and talk okay. People think that everything's all right, and they're often discharged home without much consideration. I'll go into it quickly in a second why that's an oversight often. There are increasingly alternatives to inpatient rehabilitation that might be more suitable, but sometimes they can be costly, and I won't make any comment on the National Disability Services because that's a whole nother talk for another day as well. But basically, stroke survivors in particular are having a fair bit of trouble navigating that, particularly if they've got communication or cognitive deficits. Ideally, I think it's actually in the guidelines, all stroke survivors should be assessed for rehabilitation needs and referred accordingly. So they shouldn't have to access it, but they should at least be assessed for it. Depression post-stroke is really common. So initially, neurologically, it can be a side effect, but also just changes in your role in society by default are going to give you a reason to be depressed, if you like. It's a loss, a sense of grief can compound that. It can be treated with medication, sometimes with good effect, but sometimes just modifying life to get the most out of it is actually what's required. And for that, you need a good support structure. And if you haven't been processed through the hospital system very effectively, that support structure might just not be there. Communication and cognitive deficits can lead to total isolation, especially with expressive dysphagia and inabilities to write. So we've got Enable Me as the online resource, but unfortunately not everyone can even access that, although I've heard good feedback that web-based interactions are good for people that can't get out and go to meetings of survivor groups. It can be, even if you've got good cognition, if you can't speak and communicate, it can be quite intense for the person experiencing that. Moving on. So carers, as I've mentioned before, they are the most valuable support, yet receive little support themselves. You often will have heard of carer fatigue, particularly if you've been nursing for a long time. A lot of people bring their loved ones in purely because they need a rest themselves. No one plans on becoming a carer, well, I would hope not. And the relationship changes can be very significant. So going from being someone's loved one to basically treating them potentially like your child is a very common response. And then obviously that affects relationships accordingly. Reversal of roles also too, with parents and children sort of reverse the roles where the child becomes more the parent. Again, this isn't necessarily the correct way because the person themselves might be cognitively fine. It's just their ability to communicate is impaired, but then they get treated like a child. And these are all elements of why carer education is so important, so that the carers have a good understanding of who it is they're looking out for. And as I said, discharge care plans are not provided to even start as a starting point on where they can seek help or what they should be doing, which is quite frightening, really. Oops. Cost of living, I'll just briefly go over. So house modifications, equipment adaptation therapy, modified transports, extra GP visits, all of the medications that they might be on. Anticoagulant medications, for example, are really expensive. Access to innovative treatments can be tens of thousands of dollars, and then the disability support pensions in general and the disabilities treatments in general are inadequate. Especially for working age, transport can be an issue. Can't necessarily return to driving for 3 months plus more if it's a commercial license. Weakness, vision and cognition may be impaired as well. So even if you physically can drive, you shouldn't be anyway. Doctors need to assess this. Post-discharge assessment of driving is really hard to access in Queensland in particular. I think it's only provided privately and it's very expensive for you to get your licence back. And obviously returning to work if you're working age. So as Australians have become more overweight with more heart disease and more diabetes, we're having strokes younger. So therefore we're working age, we might have young children, and workplaces are not generally well adapted to reincorporating you back to the workplace if you've had a stroke, with fatigue being a really huge one that a lot of stroke survivors report back. It really depends on your employer. Some are obviously more accommodating than others. And sex is another one the Stroke Foundation would like us to talk a lot more about with our patients. So we're sending them home. We're saying, yep, everything's back to normal, but we're not talking about sex, which is a significant part of the human psyche. And so they do have, I believe, sheets on how to start that conversation if you're not comfortable about doing it yourself. But at the end of the day, you need to acknowledge that they might want to ask and they're too scared to ask. So you need to introduce that into your care conversations. And also, if the pharmacist is about, there are some medications that can interfere with sex as well. So they can talk about that too. Oh my God, I'm really going to finish on time here. So I'm just going to finish on stroke palliation. So stroke side effect is deemed so profound as to make survival impossible. The stroke effect or the patient conditions renders surgery unsuitable or futile. So that's all the different procedures, ECR. or the resulting disability results in the survivor choosing death over lifelong disability, which is the advanced care directives. The Stroke Foundation wants stroke patients and their families to have access to specialist palliative care teams as needed. A lot of stroke units prefer to palliate on the stroke. Oh. My timer telling me. We should be assessed for basically imminent death and poor prognosis a lot earlier than we do. Was very much a culture that when someone's had a stroke, we'll wait and see how they go, and then a week might pass and obviously nothing has changed, and in the meantime they've had a lot of interventions to basically keep them alive artificially. So those predetermined conversations are really important. And a stroke-specific palliative pathway is a useful tool because stroke palliation is very different to cancer palliation. So how we do it is basically the withdrawal of the measures that are used as the secondary complications. So the aspiration pneumonia, the urosepsis, the atrial fibrillation to cause another stroke, anticoagulations, all of those sorts of things. By withdrawing those medications, natural processes will basically be hastened. Withdrawal of fluid and nutrition is a big one. So a lot of people feel morally conflicted by doing this, but the reality is that the body is capable of shutting down very quickly in the absence of fluid and nutrition, and the cancer palliation has a lot of evidence to support that. Pain management is not used the way it is in oncology palliation, but with stroke there is quite frequently significant pain from the inability to reposition in particular. So a good palliative care consult can help ascertain what's appropriate. And the other thing that can be used is non-verbal pain scales. So there's a few of them around that will enable you to ascertain if your patient has pain, even though they might not be able to speak or point. Symptom management can be very variable. Generally, in the past, it has been poorly managed, both internationally and in Australia, but over the years, I think it has actually improved. There's a lot more acceptance that palliation early is the better way to go, rather than just leaving it up in the air and letting time pass, because it's not to patients' benefit.